Yeah, I would like to especially thank Katarina because she has really done most of the work organizing this meeting. And I'm going to continue where Johan stopped and more talked about higher order processing of CT signaling. Let's see if I get it right here. Which next? So I will start talking about what we think is perhaps one of the functional roles of the C-tactile afferent system. And I'm going to talk about the interaction between the C-tactile afferent system and the pain system. And I'm going to talk about a study we just finished about placebo manipulation and pleasant touch. And the question that we were asking from the beginning when we started to record from these units is, what do we have them for? Why do we have a slow touch system? Because if you touch the skin, you will feel that immediately. You don't feel a second wave of touch, which would correspond with the signaling in the C-tactile afferent. So why do we have this system? And it wasn't easy to study in humans because when you touch the skin, you will activate the fast-conducting myelinated afferents in parallel with the slow-conducting C-tactile afferent. So it's hard to say what information comes from what system. But breakthrough came in 2002 when we came in contact with 2 patients with a selective denervation of the myelinated A-beta system, but sparing of the C-tactile system. And these patients, they are now around 60 years old, and they developed sensory ganglionopathy when they were around 19 years. So they know what it is to have a normal touch system. And of course, they provided a unique opportunity to study the effects of C-tactile system on perception and cortical processing without the A-beta system. And just the clinical, what these patients suffer most from is lack of proprioception, because when they lost the myelinated fibers, they lost proprioception. So this is just a short video from BBC of one of these patients. This is not the patient we have studied, but the 2 patients we have studied have similar disease.
Charles Fried has lost control of his body. A rare virus has ravaged his nervous system, leaving him with no sense of touch below the neck and unable to sense how his limbs are moving. Charles is not paralyzed, but he has lost his proprioception, the hidden 6th sense that tells the brain where the body is in space. Proprioception is so basic to our experience of being in the world that most of us are unaware that we have it.
So when we first met these patients, they both said that they lacked their sense of touch when they became ill. So they said they had absolutely no sense of touch. And we were, of course, very disappointed because we know that they have their C-tactile afferents intact, or they are very likely to have their C-tactile afferents intact. So if we slowly brush on them, they should be able to feel something. But I say that no sensational touch. So we did a 2 alternative forced choice experiment instead, and we brushed on the forearm skin where there are C-tactile afferents, and we asked them to say whether or not they had been brushed. And this is results from one of the patients, GL. And the first time we tried this, she was 100% correct. So even though she said that she had no sense of touch, she could still detect the brushing with 100% correct. And we repeated this, then she was around 80% correct. And on the glabrer skin, where no one has so far found any C-tactile afferents, despite Åke Wallbo, I think he says he has done 10,000 of recordings from this nerve. He hasn't seen any C-tactile afferent. And one of the first recordings he did from the forearm, he found these afferents. So it's highly unlikely that they are here. But for brushing on the glabrous skin, she was around 50% correct. So she was only guessing. And then she started to pick up some sensations from the brushing. When we informed her about the results from the 2 alternative forced choice experiments, she said that if she really concentrated, she could actually feel something. And she rated it as very weak on a scale from 0 to 100. So this is how she perceives touch on the intensity scale on the arm. And this is on the forehead where she has intact sensibility, so the cranial nerves are not affected. But interestingly, she said it was pleasant. There was no pain sensation, no temperature sensation, but a slightly pleasant sensation. But it's very difficult for her to describe in words what it is that she really feels. But there is something, and she thinks it's pleasant. And now we have tested her many times, and she becomes better and better. So now she has more a distinct sensation when we brush on her, but it's still very vague, and she says that it has nothing to do with the kind of touch she has from her forearm. And we did fMRI on her, and we were brushing on the forearm, and in healthy subjects, you see activation of primary somatosensory cortex, bilateral secondary somatosensory cortex, and the posterior insula. In GL, we had posterior insula and some motor activation as well, but nothing in the sensory cortices. And we tested the other patient, IW, and we found a very weak, just above significance, insula activation, contralateral insula. But then we, instead of using the brush, we used manual caressing, which, as Johan mentioned, and Rochelle will talk about on Sunday, is a more effective CT stimulus. And then we had a more robust, more reliable insular activation. But again, no activation of somatosensory cortices. And we have found a somatotopical representation to CT targeted touch in the insular cortex, where the forearm is represented anterior to the thigh. This is in GL and in 6 healthy subjects. And to us, this somatotopical representation suggests that this is the insula is the primary cortical receiving area and not the somatosensory cortices. And other groups have studied C-tactile targeted processing in healthy subjects, and the group with Kevin Pelfrey and Martha Kaiser in Yale have found CT-related activation of the prefrontal cortex and the superior temporal sulcus. We have done a PET study where we found robust activation of the orbital frontal cortex to CT-targeted touch. Another group in Umeå, Sweden, have found activation of the pregenial ACC in response to CT-targeted brushing. And we have looked specifically at the superior temporal sulcus, and we have done fMRI in subjects from 6 years old up to 36 years old, and we found a bilateral activation of STS, superior temporal sulcus, across ages, but there's a female-specific increase in activation that we don't see in men. So there's a correlation between the bold signal with age only in females in superior temporal sulcus bilaterally. And we don't know what this stands for, but we would like to look more into that. And this is not CT specific, because we see it both for brushing on the forearm and brushing of the palm. Then we have examined a group of patients which have the opposite kind of denervation compared to GL and IW. These subjects, they have a selective denervation of the C afferent system, but sparing of the A beta system. And what we have studied more now, but what we have published is 11 subjects. and they have a congenital sensory neuropathy type 5, which is due to a mutation in the nerve growth factor beta gene, and they are classified as HSAN5. And they all live in the northern part of Sweden. The Arctic Circle would be around here. So in the very northern part of Sweden, and they are related to each other. And they have we have taken biopsies in them, sural nerve biopsies, and they have a severe loss of C fibers, but sparing of A beta fibers. So as you can see here on the sural nerve biopsy, the myelinated afferents are largely intact, but there are very few unmyelinated fibers. And clinically, they suffer from a reduced pain sensation, so they burn each other, burn themselves, not each other. And they have a lot of joint deformations. I think that's the main problem. It's called Charcot joints. So they were actually discovered by an orthopedic surgeon who saw a lot of people coming in with severe joint deformations, and he knew that they were related to each other. So we were interested in how do these subjects perceive CT-targeted touch. So we brushed with different velocities. If you remember the slide that Johan showed, the C-tactile afferents respond optimally to 1, 3, and 10 centimeter per second. So we brushed with a range of velocities from 0.3 to 30 centimeter per second. And this is healthy controls, and the controls all preferred 1, 3, and 10, as Johan showed you. And then we did the same in the patients. And they gave overall lower ratings, and they showed no specific preference for 1, 3, and 10. So they thought that a fast brushing like this, 30 centimeter per second, is equally pleasant as a more slow brushing, 3 centimeter per second. And we almost never see that in healthy subjects. And we did fMRI in these subjects, and there was no activation of the posterior insular cortex in response to light touch. This is the activations in the controls, and this is the mask where we looked in the patients, and there was no ball response there. So to summarize on the support, CT afferents respond optimally to stimuli perceived as being pleasant. That is what Johan talked about, the correlation between the CT firing rate and the pleasantness ratings. And a selective CT stimulation in the A beta denervated patients activates insula but not somatosensory cortices. And it's not selective CT stimulation is perceived as pleasant. And following C fiber denervation, touch becomes less pleasant. And but we still think that the complete perception of pleasant touch requires integrated signal from A beta afferents and C tactile afferents, because the two A beta denervated patients, IW and GL, they don't have a like normal pleasant touch sensations. It's probably an integrated message from both sensory systems. And of course, pleasant touch is highly dependent on top-down factors, contextual factors, and homeostatic factors. Johan mentioned this as well. There has been some recent support for the C-tactile pleasant touch hypothesis from animal studies, and this is one of this was an early publication. I think it's from 2009. And they claim that they have found C fibers that respond to gentle stroking in mice. It's a bit controversial. They don't have electrophysiological recordings from these afferents, but it could be that there are actually C fibers that respond to gentle touch. And they are MRG PRB4 expressing neurons, and they may probably correspond to human CTs. and they have the same receptive field organization as the human CTs have. This is the data Johan was showing with the different hotspots of individual C-tactile units, and the receptive field structure resembles the receptive field structure of the MRG PRB4 expressing neurons. And interesting thing here, I think, is that pharmacological stimulation of the MRG PRB4 expressing neurons had what seemed to be rewarding or anxiolytic effects in the mice in a conditioned place preference test. So now I'm going to switch and talk about CT afferents and pain. The CT afferents and pain system seems to have similar anatomical pathways. They probably project in the lateral spinothalamic tract and insula and beyond. So there is possibility for functional interactions. And one of the first studies that looked at C-tactile afferents in relation to pain was this paper by Rebecca Seal. And they were looking at another set of CLTMRs that are expressing VGLUT3, which probably corresponds to human CTs. And they had global VGLUT3 knockout mice show decreased mechanical hypersensitivity to experimental models of inflammatory pain. So suggesting that the VGLUT3 neurons have an important role for the development of neuropathic pain. This has been criticized, so it might not have been a specific effect in the peripheral neurons. It might have been central effects because it was a global VGLUT3 knockout mice, but we don't really know. But that inspired us to study if there is a critical role for CTs in humans. And we have worked with a heat capsaicin model. And what you do is that you first burn the skin, heat the skin, and then you apply capsaicin cream on the area where you burnt the skin. And that creates hypersensitivity, not only in the treated area, but also outside the treated area. And the way we did the experiment was that we brushed here outside the sensitized area, and as well as in the control area. And we asked the subjects to tell which is most unpleasant, being brushed here or being brushed there. And healthy subjects, they always said that this is more pleasant and this is more unpleasant. And then we asked them to choose words for the McGill Pain Questionnaire to describe the sensation from being brushed on the capsaicin treated or near the capsaicin treated skin, and they choose words like hot burning, tender, and stabbing. And then we applied this model on the A-beta denervated subjects, or subjects that only have the C-tactile system. But to our disappointment, they said they had no feeling of, they didn't choose any of the pain descriptors to describe the brushing sensation from the allodynic zone. So the first conclusion was that they have no tactile allodynia. So without A-beta fibers, you don't have any tactile allodynia. And that was actually published before by Trede and Cole already in 1993. But then we asked them, is there any difference between being brushed on the capsaicin, close to capsaicin, and the control area? Then they said that, well, I don't feel anything on the near capsaicin, in the near capsaicin zone. So there was a change, although they didn't perceive allodynia, but they lost their normal C-tactile sensation. So we asked them to say which is weakest in a forced choice situation. Was the brushing on the control zone weakest, or was the brushing on the capsaicin zone weakest? And they all choose the said that the weakest sensation was from the intended allodynic zone. So there seems to be some alteration of the C-tactile processing in the experimental allodynic area. And we did fMRI on this, and this is a multivoxel pattern analysis. So what you can see here is areas of the posterior insula where the processing was different in the control zone and in the allodynic zone. And this is the subject GL, and this is control subjects. So there is a altered insula processing during experimental tactile allodynia. There's no painful sensation, nothing painful, but there's the C-tactile processing seems to be altered in the allodynic model. And we also found reduced processing in the prefrontal cortex for stroking in the intended allodynic zone in GL. And we saw an altered processing in the same prefrontal areas in healthy subjects when we stroke in their allodynic zone. So what we conclude is that, at least based on these two patients, GL and IW, the A-beta signaling seems necessary for the allodynic percept. But there might be a role of human C-tactile afferents as well. And they may change their role from signaling pleasantness to perhaps contribute to the allodynic sensation. We're not really clear about the details here, but I think Emmanuel Bourdinet will talk more about this on is it Sunday? Or, yeah. So there are some recent animal findings that support a role for C-tactile afferents in tactile allodynia. Now I'm going to move on and talk about how CT afferents can reduce pain sensations. We were inspired by a review paper from Siri Leknes and Irene Tracy, where they pointed out that if you're in a pleasant state and add pain, you will feel less pleasure. But if you're in a pain state and add pleasure, you will feel less pain. So this was what we were working around. And there are three animal studies that support a role for CT afferents in pain modulation. And the first one was a paper by Pearl, 2003, where he claimed that CLTMR target input may inhibit nociceptive messages already in the dorsal horn level, in the superficial lamina of the dorsal horn. And there's the Vrun 2 paper that talked about before, and Johan has talked about, where pharmacogenetic activation of the MRG PRB4 expressing neurons affect condition place preference testing, suggesting an anxiolytic role. And then there's the studies by Emmanuel Bourdinet's group showing that CLTMRs may release a protein called TAFA4, which has analgesic effects. First experiment we did was that we applied heat pain, and at the same time we were either brushing, which is CT targeted touch, or vibrating, which would be more of an A-beta targeted touch, because CT afferents do not respond so well to vibration. We were asking how painful the heat pain was. And there was a clear pain reduction when we stroked without brushing, but not when we vibrated. There was about a 15% pain reduction for stroking, and almost no pain reduction for when vibrating. But we were criticized that this could just be an effect of distraction somehow, or not specific to the CT system. So we separated the two stimuli in time instead. So we applied the heat pain first. We brushed first and then applied the heat pain, or we applied fast brush stroking and then the heat pain. And then we got the same, or we got a significant pain reduction when the heat pain was preceded by slow stroking. CT-targeted stroking, but not by fast A-beta-targeted stroking. We changed the timing between when we stopped brushing and we applied the heat pain. And the shorter duration between the brushing and the heat pain, the more effective was the pain reduction, or the larger was the pain reduction. So a short interstimulus interval gave better pain reduction than a longer interstimulus interval. And we measured some personality, some state questionnaires as well, and there was a negative correlation between pain reduction and anxiety scores, and there was a positive correlation between calmness scores and pain reduction. So the same painful heat stimulus was perceived as less painful when preceded by CT-targeted touch. And we saw less pain, the manipulation was less effective in patients with high anxiety and low calmness scores. And we are now doing an fMRI study of this. Then I'm going to finish talking about a recent study that was done by our PhD student Don Mikael Ellingsen and supervised by Siri Leknes in Oslo. And it was inspired by, we first did a study on oxytocin. So we used oxytocin nasal spray, and we wondered if that would affect pleasant touch perception, but it had no effect. We couldn't detect, in our sample at least, we couldn't see any effect of the oxytocin nasal spray on how you perceive pleasant touch. So instead we decided to do a placebo manipulation. And it was a quite complicated design. So we showed the participants a video film summarizing all the scientific evidence for oxytocin having a positive effect on touch as well as on pain. So all subjects were watching this video, and then they said that they were told that they were given a nasal spray which were likely to contain oxytocin. And then we did the testing during fMRI, so we applied painful stimulation, brushing, or innocuous warmth stimulation, and the subjects were instructed to rate the sensation when we had applied it. So we applied a stimulus, there was some delay, and then a VAS rating, and there were pain stimulus, brushing stimulus, and innocuous warmth. And the subjects believed in our manipulation. We asked them if they thought the nasal spray would make pain less unpleasant, and they agreed on that, and they thought the nasal spray would make stroking more pleasant, warm touch more pleasant, and we had some control statements that were not mentioned in the videos, and they didn't think it had any effect on that. So they seemed to believe that the oxytocin nasal spray will actually make touch more pleasant and pain less painful, and warm more pleasant. And that is what we found as well. So there was a slight increase in pleasantness rating for stroking touch in the placebo compared to the control condition. It was a slight increase in how pleasant they thought warm touch was in the placebo compared to control. And they thought the pain was a bit less in the placebo condition than in the control condition. So our placebo manipulation made pain less painful and pleasant stimuli more pleasant. And the fMRI, we did an fMRI analysis and looked in the somatosensory areas as well as in the insula and thalamus. And for pain, we saw a reduction in insula S1 and S2 when we contrasted placebo minus control. And for brush, it was the opposite, with an increase in insula and S1, S2 and thalamus. And for warm touch, it was also an increase in these areas. And then we looked at more reward-related areas, and there was when contrasting placebo minus control, there was an increase in fMRI signal in nucleus accumbens and periaqueductal gray during stroking touch, same for warm touch, and we saw an increase in nucleus accumbens for painful touch. And we correlated the placebo response with bold activity, and there was a correlation in the ACC, in the orbitofrontal cortex, nucleus accumbens, midbrain for stroking touch, and in the nucleus accumbens, amygdala, and midbrain for warm touch, and in the ACC for pain touch, for painful touch. So we proposed a mechanism for how this might work. So we think that during the placebo manipulation, you activate an emotional appraisal mechanism that then influences the somatosensory and insular processing. So if you have an expectation that the stimulus will become more pleasant, you will get an upregulation of processing in the somatosensory and insular cortices. But if you expect that the placebo manipulation will reduce pain, you will get a down-regulation of activity in these areas. Okay, that was it. Johannes Klein-Tåke Valbo, and he has been very important for the peripheral discoveries here, and Catherine Bushnell at NIH has been very important for studies of central mechanism of the C-tactile deficit. I would like to thank all the other collaborators. Thank you.